Good morning, good afternoon, and good evening, everyone. I'm Paolo Tarantino from the Dana-Farber Cancer Institute, and it's a pleasure to welcome you at this Medscape program on advanced hormone receptor-positive breast cancer, oral SERDs in focus. I'm extremely lucky today to be joined by two amazing faculty, and I will first introduce Dr. Eva Ciruelos, who is a medical oncologist at Hospital 12 de Octubre and co-chair of the SALTI group. Eva, thank you for joining us today. And I would also like to introduce Valentina Guarneri, Professor of Medical Oncology at University of Padova and Director of Istituto Oncologico Veneto. Valentina, thank you for joining us.
Thank you.
Wonderful. So we only unfortunately have half an hour, but we'll make sure to make it as intense and packed with new data. And there's a lot of new data to cover in this space of hormone receptor positive breast cancer. But first of all, a little introduction. Why is this disease so important in breast oncology, this subtype? Well, because it's the most common. We know that approximately 2/3 or more of all metastatic breast cancers are hormone receptor positive, HER2 negative. So they have expression, usually overexpression of estrogen receptor and sometimes also progesterone receptors, and they do not have HER2 amplifications. And we know that these tumors tend to be driven by hormone receptors, which is why we've been developing in time multiple agents to target the estrogen receptor pathway. And you can see here a timeline of agents developed across, endocrine treatments, biologic treatments, and in general, you can see that since the 70s, endocrine treatments have been the key treatments for hormone receptor positive HER2 negative breast cancer with tamoxifen, and then the wave of the AIs, the first SERD, fulvestrant, which is an injective SERD. More recently, we've seen CDK4/6 inhibitors, PI3K targeting agents, mTOR inhibitors, the first AKT inhibitor, and the first oral SERD. But now we're seeing really a wave of oral SERDs expanding into breast oncology and showing improved outcomes for patients with hormone receptor positive metastatic breast cancer. So here's just a short depiction, a table including some of the recent studies that have been conducted with novel SERDs. And when I say SERD, I mean selective estrogen receptor degrader, that usually they've shown to be active even when SERM modulators like tamoxifen or AI stop working. And we have one of these that is approved, and it's elacestrant, and we have several of these that have positive phase 3 data, including imlunestrant, vepdegestrant, camizestrant. All of these are either oral SERDs or novel endocrine agents. For instance, vepdegestrant is also a PROTAC and is able to degrade also the estrogen receptor through the proteasome. But in general, they are novel endocrine agents. They've been tested in large phase 3 trials, including hundreds of patients, which have some key differences. You can see that all of these were in second line, apart from SERENA-6, which was kind of a weird first line, as we will see. And most of these at patients that were pretreated with CDK4/6 inhibitors, but not in all of them they were strictly required. Some of them allowed prior fulvestrant or not, and some of them allowed prior chemos. Actually, Emerald only allowed prior chemo. The other trials did not. So these differences can have major impacts on the results, and I think it's important to remember this. And another important thing to remember is that one thing that all of these trials showed is how important ESR1 mutations are. So ESR1 mutations are mutations in the gene for the estrogen receptor. We know that these emerge. They are usually absent in the early stage setting or a metastatic diagnosis, but they emerge upon endocrine treatment. And the first trial really showing improving and bringing ESR1 mutation to the clinic was the Emerald trial. And with this, I would like to ask our first faculty, Dr. Valentina Guarneri, to review a little bit what is the data that supported the first approval of an oral SERD in breast oncology, elacestrant, the Emerald trial. Valentina, could you guide us through Emerald and any recent important phase 3 trials in the second line with novel SERDs?
Sure. Thank you, Paolo, for the introduction. So I think all of you are familiar with the Emerald trial. So just a quick summary. So this trial was designed to evaluate elacestrant versus investigator choice standard of treatment. And as you can see, patients were allowed to have one or two prior lines of endocrine therapy, and the pre-treatment with CDK4/6 inhibitor was mandatory in this trial. So this is very important. And as you mentioned, up to one prior line of chemo for metastatic disease was also allowed, and approximately 20% of the patients in this trial received also chemotherapy. So this trial was designed to enroll all comers independently by the presence of the ESR1 mutation, and the primary endpoint was PFS per blinded in central review in all patients and in patients with the ESR1 mutation. So the primary results of the Emerald trial was the demonstration of improvement in PFS, which was observed in the intention to treat population. But when looking at the data according to the SR1 mutation, the benefit was driven by the SR1 mutation cohort. And what is very important in my view in terms of the importance of this data is that it was demonstrated that the longer is the prior use of prior CDK4/6 inhibitor, the higher seems the benefit of switching to a single agent endocrine therapy directly targeting the SR1 mutation as elacestrant. So in the patients with prior exposure to CDK equal or higher than 12 months, we have a median PFS with elacestrant which exceeds 8.5 months. So in terms of efficacy, very important data with, I have to say, a good safety profile. When moving to the new data, because as you mentioned, elacestrant is not alone in the clinical scenario. We have seen at San Antonio the presentation of the Ember-3 trial. This trial was designed to enroll patients with recurrence or on within 12 months of AIs for adjuvant setting, plus or minus CDK4/6 inhibitor. So this was not, the CDK4/6 inhibitor was not mandatory as treatment. And for patient in metastatic disease, progression has to have on one line of treatment with the AIs plus or minus CDK4/6 inhibitor, and no other therapy was allowed for advanced breast cancer. And here is important to remind that prior CDK was described in approximately 65% of the patient. The majority was pretreated with palbo. So these patients were randomized to imlunestrant single agent, standard of care endocrine therapy, fulvestrant or exemestane, or the combination imlunestrant plus abemaciclib. And here the comparison were between imlunestrant versus standard endocrine therapy or imlunestrant plus abema versus imlunestrant. The trial demonstrated the superiority of imlunestrant versus standard of care endocrine therapy only in those patients with the SR1 mutation. We're looking at the combination imlunestrant plus abemaciclib. This was superior to imlunestrant alone, independently by the presence of ESR1 mutation. So these were the main data presented at San Antonio. And if you go to the next one, here we have the safety profile. When looking at the safety profile of imlunestrant single agent, very few side effects. And when looking at the combination with abema, of course, we pay these side effects of the well-known side effects of abema, in particular the GI toxicity, but you can see mostly low grade. Why we are mentioning also safety? Because at ASCO we have seen the presentation of the patient-reported outcomes from the Ember-3 trial, and here the main summary of the results. So the global health score and the quality of life, as well as the functional domains, were maintained across treatment arms. And it is important important to note that these were maintained with imlunestrant and abema, despite the fact that the patient reported items in terms of diarrhea and nausea and vomiting were increased for those patients treated with the combination. So once again, from a quality of life perspective, the superior efficacy of a treatment may in part mitigate the negative impact of what we pay in terms of increased incidence of adverse event, which is something that is very common when you combine different treatments. And when looking at the imlunestrant versus the standard of care endocrine therapy, no significant differences, but numerically favored the imlunestrant arm in both the longitudinal and time to deterioration analysis of global health score and quality of life. It has been, in my view, probably slightly too much emphasize this side reaction with fulvestrant, but in the end here we have an all oral drug versus an intramuscular injection. In my clinic, I have to say that is not a good important issue, but this is what was reported by the trial. So I think that the possibility of having an oral combination can be important. And the last trial I want to summarize for you is the Veritac-2 study. This is a study evaluating the PROTAC vepdegestrant versus fulvestrant. In this trial, as you mentioned, one prior line of CDK4/6 plus endocrine therapy was allowed, and no more than one additional line, but with the endocrine therapy alone, no prior SERD and no chemo for advanced breast cancer. And the main results, again, a patient population not selected for having ESR1 mutation, but ESR1 mutation as stratification factor. And the main data are the superiority of PFS by blinded independent central review observed in the ESR1 mutant cohort of patients, but not in all comers. OS data immature, safety profile totally reassuring with very low adverse events leading to dose reduction or discontinuation in the vepdegestrant arm.
Thank you so much, Valentina, for this little marathon of phase 3 trials. I think everybody's realizing how exciting this field is becoming. We are in so many new drugs. These are just the start. There are several others that are coming, and not only SERDs, all of this new generation SERCAs and CERAN, and etc. But I would like to ask you both, and I will start from Valentina, a little comment on all of this. How do you think we're gonna choose which one of these agents to use, since all of them as monotherapy improve outcomes? And do you think that, the side effects seem to be different or the same? What is your perception of the field in the second line, Valentina?
Yes, I think that, of course, I will start by the last presentation in terms of what can be the positioning of vepdegestrant. Of course, when looking at this data and considering that we already have oral SERD already there in second line or third line treatment, maybe we can consider this landscape a little bit crowded. But I think that as you highlight, the patient with the HR positive disease really derived a great benefit from the endocrine treatment. So also considering that we have now data, and we are starting to have trials in adjuvant setting with oral SERD or in first line combination, having new endocrine agents, I think it's very, very important, and also to be considered as a backbone to be combined with the PIK3CA inhibitors or with CDK4/6 inhibitor. It inhibitors in other contexts, also thinking about the shift of CDK4/6 in the adjuvant setting that really is going to change the scenario of our patient in metastatic disease. For Ember-3, I think that the combination, in my view, is very intriguing because it has been shown that the combination imlunestrant abema seems to work even in the presence of PIK3CA mutation. So it seems like a strategy that can really be used for those patients without a driver, because now this is the scenario where we have less strategies available, but also in case you have a situation where you cannot test, and I think this strategy can be worthy.
Thank you. I couldn't agree more. And so I'm going to throw it back instead to Eva and ask her the hard question. So if tomorrow, let's say if today you had all of these drugs already approved, the one we discussed about, how would you choose which one to give to your patient? Do you think we have right now a way to choose, or it's just very hard? What's your opinion on this?
Yeah, as there will be no direct comparisons, I'm afraid that we'll have to choose. First of all, I would check on my patients' characteristics. Our Emerald patients are different from Ember-3 and the PROTAC trial because they are more heavily pretreated, even with prior chemotherapy allowed. And Emerald is the one that confirms the information on prior endocrine sensitivity. So for me, for a more pretreated patient, especially if she's been on treatment for at least 12 months in the prior endocrine line, I would choose in favor of elacestrant. But this is still very, very hard to make proper decisions. There are no direct comparisons. There won't be.
I absolutely agree. And to make things harder, we just saw in a plenary session some important data being presented that have shaken not only the agents available in the hormone receptor positive breast cancer space, but also the paradigms with which we treat our patients. So Eva, I will ask your help to review the SERENA-6 results presented at ASCO.
Yes, this is the other very different way of moving forward with what to do with patients who are not still in clinical progressive disease, but they become positive for this particular mutation that is the SR1. So SERENA-6 is a phase 3 randomized trial that was presented in the last ASCO meeting at the plenary session. In that trial, patients with advanced breast cancer in the ER-positive, HER2-negative disease were tested for ESR1 mutations in ctDNA once every 2 to 3 months. All patients have received at least 6 months on prior therapy, first-line therapy with a combination of aromatase inhibitor plus any type of CDK4/6 inhibitor, palbo, or abemaciclib. And patients who were found to have a positive mutation for ESR1 and did not have any type of radiologic progressive disease were randomized to still maintain CDK4/6 inhibitor plus aromatase inhibitor, or to change to maintain the same CDK4/6 inhibitor plus camizestrant. So this is the main results. The main objective was investigator-assessed progression-free survival. There were a total of 3,256 patients who were tested for ESR1 mutations. Of them, just 548 patients have at least one positivity for ESR1 mutations detected. From them, just 315 were randomized to receive camizestrant versus control arm. Why these numbers? This is because nearly 66% of patients who become positive for ESR1 mutations in the ctDNA were at that moment in clinical or radiological progressive disease. So this has to be taken into account while the patient becomes positive. We should test carefully for radiological assessment because she could be in clinical progressive disease as well. So regarding to results, at an interim analysis with a median follow-up of 12.6 months, the median progression-free survival was favoring the camizestrant arm 16 months versus 9.2 months with a hazard ratio of 0.44. That was highly significant, and the median time until deterioration in patient-reported global health status and quality of life was also favoring camizestrant arm with a hazard ratio of 0.53. We have to say that regardless on these numbers, initial numbers on PFS2, these numbers are not still mature, neither the overall survival results, as even when there's a trend that favors PFS2 for camizestrant treated patients, this group did not reach the specified threshold for an alpha level of P of 0.0001. So it's not still statistically significant. Well, we have to have a review as well on safety profile, even when there were similar number of patients who stopped treatment due to adverse events from 1.3% on the camizestrant arm to 1.9% in the aromatase inhibitor arm. There were some new toxicities reported, like photopsia, that was affecting to 20% of patients, just one patient with a grade 3. And the most common toxicity was neutropenia, led by CDK4/6 inhibitor that was grade 3 in 45% of patients in the camizestrant arm and 34% in the aromatase inhibitor arm. So to conclude, this is the second phase 3 trial after PADA-1 trial that tested a similar hypothesis that confirms that changing into an oral SERD in this case is beneficial in terms of progression-free survival for patients who have been treated with a prior aromatase inhibitor plus CDK4/6 inhibitor and who they're not still a clinical progressive disease, but they become positive for ESR1 mutations tested in ctDNA assays.
Thank you for reviewing this important data, Eva. And so, we, as you mentioned, we now have two phase 3 trials that confirm that this is, associated, this strategy with the clinical, with a benefit in clinical trials. But the question is, can we do it? Is it feasible in clinical practice? So I will throw first at you this hard question. Do you expect it to be feasible to monitor patients so often with ctDNA, both from a practical standpoint and a financial standpoint?
Yes, that's the most important questions. For me, SERENA-6 has still some limitations. First is that the majority of patients were pretreated with palbociclib, nearly 76% of them. That is maybe not representing our standard first-line therapy, that is including abema or ribociclib. Second is that we have to implement this type of testing in the clinics. This is really hard. And in SERENA-6, Guardant360 was the assay that was chosen, but still there are many other options. In PADA-1, there was a local lab test, a digital PCR test, so which is the best molecular tool to detect these patients. Maybe the third limitation is that 14% of patients in the control arm, just 14% of them, were treated with an oral SERD after progressive disease. And as Valentina has mentioned, maybe this will become the new standard therapy in the second or third line setting. And fourth, for me, the most important criticism is that we don't have follow-up enough to reach PFS2 and overall survival results. So maybe we are just anticipating the moment in which we implement this second line treatment that could be started at clinical progressive disease. Are we really changing the course of this disease, affecting long-term outcomes, overall survival? Because as you've said, Paolo, this is a way of changing our evaluation of our patients and implementing some molecular tools that are expensive. Maybe they create some stressful situations for patients. And until we don't have long-term results, in my opinion, we should not recommend this type of assays by now.
Thank you for this clear answer. And I will throw it back to Valentina and ask her if she believes that these data are practice changing. And I think here we can divide, the part of the drug, if this data should support the drug approval, and if instead they should support changing this strategy until we have OS data. But also I will ask her a comment about quality of life, because many were surprised by such an impact of the drug, of the strategy on quality of life. And how did you explain that to yourself, Valentina?
Yes, okay. So the point is that, of course, from the standpoint of considering this for drug approval, I have to say that as a strategy overall can be very intriguing, but in the end, to me, to see camizestrant has to be approved in this context. I would have preferred to see a comparison with fulvestrant, because we already had the data of PADA-1 showing that in case of the rise of ESR1 mutation, fulvestrant, which of course is not the optimal drug for targeting ESR1, but is better than AI. So I will prefer to have this as control arm in terms of gaining ground to support the reimbursement, but also the mandatory crossover. So here the point is worthy to have camizestrant at molecular progression is better than offering it at clinical progression. So that's this is was also discussed by Eva. But again, such a trial probably would have been much more complicated, because of course you would have designed the whole trial also taking into account the third line therapy, and of course this is not so easy to do. And at the time probably of the designing of this Serena 6, probably this establishment of oral SERD in ESR1 mutant at progression upon CDK4/6 was not so established. In terms of quality of life, yes, I have to say that I was totally surprised by this data, and so because probably I have to say that I have no particular explanation for this. We also discussed about the fact that probably the patient, but the results was the patient were blinded by the results. So actually, I have to say that personally, I have no particular hints on this. I would like to hear your comments on this.
I would say I hope that is related to the fact that the drug managed to make the patients feel better, maybe also with less joint aches as arthralgias compared to AIs. Maybe the photopsias are not so bad. Then there is the point, like if a patient has photopsias, maybe the patient figures out that she's on the experimental arm, and that boosts quality of life. So there's many potential questions. And then some opinions I've heard that were intriguing is that maybe even in the absence of anatomical progression, the rise of tumor fraction in the blood can already make the patient feel worse somehow. And so maybe improving that with camizestrant helps. So I think we're going to need to wait to see the whole quality of life questionnaire results. Yeah. And I think we're going to see that soon. So let's wait for that to have an in-depth discussion. But for the moment, I wish I could pick your brain for hours. We were allocated only half an hour today. So I would like to really thank you both for your insights on all of these trials, to really thank everybody that joined this short call, this short program, Medscape for powering it. To claim free credits, you can scan this QR code. And I believe we are at the end of the program. So once again, thanks everybody for joining this. Let's look forward to many new data coming at ESMO, at San Antonio. And I wish everybody an amazing summer vacations, and especially Eva and Valentino. Thank you so much for joining this program. Ciao.
Thank you. Bye-bye.
Thank you. Thank you. Great job. Thanks. Ciao.